So today we're going to be talking about transfusion, looking at different products, different times when we use them and when to use them and when not to. This talk is quite fact heavy rather than being more case based like some of the others, so take your time with it. So before we dive straight into my cardinal rules, it is worth mentioning just a basic understanding of how transfusion works in terms of the laboratories and the products. What we have is a constant supply of donors and people needing transfusions. If there's more people needing transfusions than donors, then we run out of products. And if the products are being used on people that don't need them and the supplies run low, then people that do need them might go without. And that is why we sometimes need to be quite strict with giving out products. I'm sure you can imagine at the time of this video being made, with people being quarantined, that not many people are getting to the donation centres. This is the exact example of a time when supplies might be running lower than we would like. Anyway, let's dip into the cardinal rules. So the first major rule with transfusion is that don't transfuse with products if there's a better or safer alternative, or if you don't need to at all. And this goes completely against the second tip, which is that no one should die from not receiving blood products. We should never have a situation where someone exsanguinates or bleeds out because they haven't had the products they need. And so what we're trying to do is to always strike a balance between these two rules. If someone is anemic or has a clotting difficulty, if you have the time, you try and find the underlying cause. Products can often mask an underlying problem that's going to recur after some time. So the first thing I'm going to talk about, we have a variety of different topics, is irradiation, because this does confuse people, and I think it's worth understanding what it is and why it matters. So irradiation is simply the process of using gamma or X-rays to kill the lymphocytes that are left in the components, and this is in cellular components. So red cells, platelets, and the occasional white cell transfusions that we use very sparingly. The reason to do so is that in some patients with certain compromises in their immune system, these lymphocytes within those products could cause a reaction and they could start to attack their new host. Transfusion-associated graft versus host disease is pretty much 100% fatal. It's extremely rare, but when it does happen, it's not good. So these patients are usually ones that have no T lymphocytes of their own due to various reasons. There is a full list on every transfusion form in doubt. So if you're not sure, you should always have a look at the list and look at the letters and a full history from the patient. And as I said already, this is when we're using red cell, platelet and granulocyte transfusions. So it's not important in FFP or cryo or anything like that. So you can pause the slide if you wish and just have a look at, this is just the list taken from the Transfusion Handbook of reasons to use irradiated products. But as I said, it's on all the forms as well. So we're going to talk a little bit more about red cells specifically. And let's start with the thresholds, when to use them. So in this country, we use something called a restrictive threshold, where we accept that less than 70 is likely to make people feel unwell. When compared with a liberal threshold, so 90 or 100, in various trials, it's been found that restrictive is at least as good for patients. If you've got a pre-op patient or someone symptomatically anemic, then you can consider giving a unit if it's less than 80. And we tend to use just one unit at a time. In unwell medical patients, so your critically unwell sick patients, you can aim for 90 grams per litre if they're in with an acute coronary syndrome, an acute stroke, or a bleed in the brain. In septic patients, this is another group with an exception to the restrictive rule, and in the first few hours, then you would aim for above 90 if they're showing signs of tissue hypoxia. But as the hours roll on, this becomes less relevant, so it's more of a judgment call with septic patients. The main exception to all of this, though, is the elderly patients, especially those with cardiorespiratory problems. Most of the evidence of liberal and restrictive is on younger patients, so you need to go on symptoms, history, and need for these older patients. So let's talk about viscosity. So we're very wary of transfusing our patients that may have hyperviscosity. So what you're doing when you transfuse these patients is taking a bag of packed red cells, which in itself has a high hematocrit, already a very thick mixture, and you're adding it into a patient whose blood is already slightly thicker or much thicker than it should be. And what you're doing is overall increasing the viscosity of that blood and increasing their risk of having a stroke or an MI. And that's because their blood is literally becoming thicker like gravy or treacle, and your circulation becomes impaired. So the most common causes for this to happen, they're usually hematological, so you may not see them on the wards that much, but patients with Waldenström, sickle cell disease, myeloma, or polycythemia, they can find themselves on medical wards or surgical wards, so worth knowing about. You can occasionally see really viscous patients in septic, especially in the really dry patients, so just be aware. Usually we would say transfuse but with fluids, but if you're not sure, just get some senior input. Okay, so iron deficiency. Really, with this, I'm going to talk about hematinic deficiency. Most of these patients, they don't need transfusion unless they're symptomatic. So a very common scenario is on, say, an acute medical take. Patient will come in with a fairly low hemoglobin, an obvious iron deficiency pattern, and will receive 4 units and be sent home. I've seen that quite a few times. And really, it's not necessary. What you're doing is exposing them to the risk of transfusion without necessarily altering their outcome. So if someone comes in with chest pain or congestive heart failure because they're very anemic, then sure, give them a unit and that'll buy some time for the iron to work. But really, IV iron is very safe. It's traditionally got a bit of a bad rep. The older compounds did have a higher anaphylaxis risk. The newer compounds is less than 1 in 250,000. And compare that with 1 in 7,000, give or take, adverse reactions for transfusion products. So it's extremely safe, IV iron. You can often, if the patient's relatively well, use PO iron. I think with oral iron, again, it's got a bad rep because patients don't tolerate it and they don't take it. It's worth, if you're prescribing it, warning them of the side effects, explaining that, you know, your gastric upset, constipation, diarrhea, or dark smelly stools can be a side effect. If they're not complying with it, then you can try giving oral iron every other day, and that again can work, but it does take longer. And the principles with your other hematinics, your B12 and your folate, are similar. So replace, don't transfuse unless absolutely necessary. So you may end up looking after sickle cell patients on medical, surgical wards, obs and gynae, pediatrics, or anywhere really, and especially so in district general hospitals where they can come in on the acute take. They've got quite complex transfusion needs, a sickle cell cohort. There's a high risk of hyperviscosity, as we mentioned before, and vaso-occlusive events. And that's just the nature of their disease. It's a very complex interaction between damaging the wall of the vasculature and the sickle cell shapes themselves. The most important thing when considering sickle cell transfusion is you need to know their baseline. Even if their baseline is low, you don't really get a benefit from transfusing above it. So indications for transfusions in the normal sense of adding in extra blood are actually very few with sickle cell patients. We call those top-ups. More often what we do with these patients is take out the sickle cell blood that they've got and give them some new fresh blood, and that's called an exchange transfusion. The lab, when they're getting hold of blood for these patients, it can take time, and that's because they need sickle cell negative blood, so blood not from a donor with sickle cell disease. And bearing in mind the ethnic makeup of these patients, that can't always be very easy. And you're also looking for fresher blood, i.e. blood that's going to last longer in the circulation. The other problem with the sickle cell patients is that they can have several alloantibodies. So over time, as they get transfusions, they become more and more resistant, build up antibodies, and it can be harder to find properly matched blood. So with these patients, the major rule here is don't transfuse without hematology input. Okay, so let's switch tack slightly and go to the pre-op patient. So we're now in, say, a surgical pre-op clinic. So in these clinics, if your HB is less than 80 pre-op, then you can think about giving a single unit. But really, you want to find the underlying cause. So you need to identify and treat the anemia. not just give the products at the last minute. And the same goes for clotting as well. So in these patients, elective surgical patients, between 15 and 50%, depending on which study you read, of the red cell transfusions are inappropriately given, or otherwise could be avoided. So clotting screen is important as well. So it's easier to investigate an abnormal clotting screen 2 weeks before the op than 2 hours. Obviously with emergency patients, that's not quite so easy. And the really important thing with the clotting screen in these patients is that a bleeding history is much more predictive for bleeding during surgery than an abnormal clotting test. So when you sit down with these patients, whether or not their clotting is normal or not, I would always ask, have you had any major bleeding challenges before? Have they had surgery before and bled unexpectedly? Have they had any major trauma and had to have bleeding products? Or for the ladies, have they had a child and had unexpected excessive bleeding during childbirth? Consider their anticoagulant use and make sure the bridging plans are in place. For your pre-op anemias, the most common cause is iron deficiency. Okay, so it's worth just having that at the back of your mind if you see a low HB pre-op. Okay, so let's talk a bit more about platelets and clotting products. So platelets should be self-explanatory. When we talk about FFP and cryoprecipitate, so FFP is fairly straightforward. It's just plasma, fresh frozen plasma. You need to give quite large volumes because the amount or concentration of the clotting factors in there is relatively low, as it is in anyone's plasma if you were to just take it out with a needle. It's not concentrated. So the large volumes can be a problem because of circulatory overload. That's always worth thinking about with FFP. Cryoprecipitate is the insoluble stuff you get when you thaw FFP. And its main purpose traditionally was actually to treat haemophiliacs because it's quite rich in factor VIII. It's also got lots of von Willebrand factor and fibrinogen. And its main purpose in modern transfusion medicine is for fibrinogen replacement. So let's talk first about platelets and reasons to give them prophylactically, i.e. before the patient is bleeding. So if you've got someone who's got a temporary thrombocytopenia, so that's someone who's could be generally unwell, most commonly chemotherapy patients, or any other cause that you think is going to get better, the threshold is 10, and you give 1 pool at a time. If the patient is septic, you can increase that to 20. But in irreversible thrombocytopenia, so patients with severe myelodysplasia or other problems, we tend not to give it prophylactically, only when bleeding. If you come across ITP patients, so immune thrombocytopenia patients, again, we don't give them just because the platelets are low, because those antibodies will destroy the platelets fairly quickly. So in ITP, we only give unless the patient is bleeding. And if you do occasionally come across the microangiopathy conditions, so TTP, hemolytic uremic syndrome, DIC, then we don't give platelets in these patients because it tends to drive the process. So those platelets are being consumed and all you're doing is adding fuel to the fire for more clots to form. So unless the patient is having life-threatening bleeding, we never give platelets to those patients. More often than not, you're going to be giving platelets therapeutically. So it's part of the major hemorrhage protocol, and in major bleeding, we keep the platelets above 50. If you've got someone that's had a spontaneous cerebral bleed, a traumatic brain injury, or multiple trauma, then that threshold rises to 100. I appreciate Leicester's not a trauma centre, but with the other two, we do sometimes see them, so it's worth bearing these numbers in mind. In non-severe bleeding, consider if it's below 30. Although my tip for you is to try and avoid this. You can try some tranexamic acid in the appropriate circumstances, and this can reduce the need to give urgent platelet transfusions. Patients on antiplatelet agents, so aspirin, clopidogrel, ticagrelor, whichever, if they are critically bleeding, sometimes we can use platelets to try and slow that down. Again, you'll look at where the bleeding source is and try and stop it mechanically, use tranexamic acid, but sometimes giving platelets can be done. When we're looking at procedures, this is probably the most common reason people try to order platelets. And I've got just the list of numbers here. This is taken straight out of the guidelines, so you can pause the slide and have a look. But the major thing here is that, with the exception of neurosurgery and spinal and epidural catheters, it's actually not very high to safely manage these patients in these settings, so you don't need to give platelets all the time. With FFP and cryo, it's much less clear cut. With platelets, we've got nice clear thresholds. With FFP and cryo, there's just no firm evidence of either actually working very well in procedures. So the abnormal clotting, as I've already said, isn't a great predictor of bleeding. You're better off doing a full bleeding history, a family history, and a drug history. I know I've said it before, but it's definitely worth remembering. So in patients with an INR of less than 2, there's a very limited impact of giving them FFP. And I've put this in because it's quite a common phone call that the haematologists get, is asking if FFP would be useful in this situation. The answer is almost certainly not. Combined with the fact that you do risk giving a litre and a half of fluid, which can lead to overload. An INR of over 2, and you need to do a procedure, it can be considered, but you need to remember it's not evidence-based, and you're carrying those transfusion risks. More strongly recommended would be giving some vitamin K and trying to wait a couple of hours, a few hours if possible. So cryoprecipitate, remember 2 pools of cryo is considered 1 therapeutic dose and should raise your fibrinogen by 1 gram. You can consider this if the patient is high risk for bleeding and the fibrinogen is less than 1. And your high risk patients are those with the relevant history and family history and so on. So let's talk about liver disease patients. So in patients, especially those with advanced hepatitis or cirrhosis, you can often get deranged clotting, and that's because there's a reduced synthesis of the vitamin K dependent factors. These are normally made in the liver. Remember though that the anticoagulant factors like protein C and S are also made in the liver, so you tend to get a bit of a reset. So rather than just the procoagulant factors being reduced, everything's reduced, and you get a bit of a reset level. With platelets, platelets will often fall in cirrhosis patients, and that's multifactorial. The platelets can get trapped in the spleen and sequestered there. The production goes down because of the fact that thrombopoietin, which is the platelet hormone, is produced in the liver as well, also contributes, and there's various other factors, but the net result is that the platelets tend to drop. They drop severely in end-stage cirrhosis. So when you've got a liver patient and you want to do a procedure, usually these are going to be paracentesis or variceal banding, there's no evidence to give FFP before these procedures. If you've got someone who's got varices, giving that volume may well actually make things worse if you've got that extra circulating volumes. So there's no evidence that we're going to improve these patients' outcome. If they're bleeding, that's another factor, and then it's a clinical decision at that point. Vitamin K, tranexamic acid, more likely to help here. So, disseminated intravascular coagulopathy. Patients who are septic, who are having complications in pregnancy, anyone who's generally really unwell can develop DIC. And what's happening here is the clotting system loses its normal control mechanisms and you get this pathological activation. So you've got these microthrombi using up the platelets, the clotting factors. And this is the situation I alluded to earlier, where adding in platelets and clotting factors to this is just adding fuel to the fire. You're giving more material for more microthrombi. And these microthrombi will appear in the kidneys, the brain, anywhere you can think of. So when we're trying to diagnose this, these patients, they'll often have thrombocytopenia, there's prolonged PT and APTT, and low fibrinogen. If you're wondering whether your patient may have DIC, you can use a calculator. So the ISTH calculator is probably the most well validated one, and you can find that online. That's very reliable. So if these patients are not bleeding, we do not give products because you're adding fuel to that fire. If they are bleeding though, then something needs to be done. So with these patients, keep the platelets above 50 as we would in a major hemorrhage protocol. You can give the FFP if they're bleeding and they have the prolonged clotting screen. Standard dose of FFP is 12 to 15 mils per kilo. So here you can see where your danger of overload and so on comes from. It's quite a big volume. If the fibrinogen's less than 1.5, then you can give cryoprecipitate. Let's talk about prothrombin complex concentrate to finish. So PCC, also known as Octaplex or Beriplex, which are the brand names, and we use this for warfarin reversal in life-threatening bleeds or intracranial hemorrhage. This is a concentrate of clotting factors that counteracts the effects of warfarin. It works fairly quickly, but wears off after several hours. So for that reason, you want to make sure the patient's got vitamin K on board. You don't want the prothrombin complex concentrate to wear off and for any bleeding to resume. So make sure there's some vitamin K on board. Tranexamic acid, almost always a good idea. So definitely consider using this. And together with the vitamin K, it can often be enough. But in life-threatening bleeds, PCC is indicated. It's not without its problems. So there is a small thrombotic risk, especially in those who already have a tendency to clot. So those that have had previous DVTs or PEs, strokes, MIs, have a higher risk. There is the cost factor as well, so it's not cheap, so we use it when we need it. So with warfarin, it's fairly straightforward. DOAC reversal, much more complicated. It's limited usefulness with DOACs, and that usefulness does tend to wear off as time after the last dose of your tablet goes on. So worth discussing, but not always worth using. Right, and that's about it. So further reading, so transfusion is a huge topic. I've tried to get through a lot in not that much time. So the BSH guidelines on platelet transfusions are really precise and prescriptive, really worth reading if you're not sure. There are also some BSH guidelines on use of plasma products, so FFP and cryo. They're a lot more vague, as you've probably guessed from this presentation. Worth knowing are guidelines on the MHP, just in case it ever happens. You want to know exactly how to run things or how to be a part of the team. And finally, the JPAC handbook on transfusion medicine. So this is free online. This is aimed at all doctors, not hematologists, but is really useful, and we still refer to it quite a lot. So it's free and very well written, so worth checking out. There will be another video coming soon on how to deal with transfusions and the adverse reactions. So hopefully you'll join me for that one. Thanks for listening.